So the factors I consider in choosing second-line therapy include and somewhat differ between whether the patient was previously on crizotinib or were they on alectinib. So previously, before the approval of alectinib as first-line treatment, with crizotinib, the pattern of metastatic disease would play a role to some extent. So for example, if there was one place of metastatic disease, we would call it, that was progressing, we call that oligoprogression. Oftentimes I would think about giving focused radiation to that area and continuing crizotinib. Now I've done that a lot less with alectinib and brigatinib being approved for second-line treatment, but that is an option to consider, particularly for oligoprogression. If patient's more symptomatic or there's other areas of progression, I do think about switching to alectinib or brigatinib, and that's clearly an indication for changing treatment from crizotinib to a next-generation ALK-TKI. And often those patients can re-respond and have excellent responses to alectinib and brigatinib, including in the CNS, where these drugs get excellent penetration across the blood-brain barrier. They can often have intracranial responses. So another thing that I've done to help manage these patients is if the patients have asymptomatic brain metastases, I often do not use whole brain radiotherapy and often move to these ALK inhibitors and they have excellent blood-brain barrier penetration and excellent intracranial responses.